Hi, this is Dr. Janson, and in this video I'd like to talk about plantar fasciitis. That's heel pain and some arch pain sometimes, especially in the morning when you wake up. It really hurts. You put your foot down, but then you take a shower or you walk for a while and it starts to feel better. But then later in the day, with more standing or walking, the pain starts to come back. That's very typical of plantar fasciitis. Another frustrating thing is that the pain can go away sometimes for days, and you think, wow, that's gone. Thank goodness, that was really hurting me. And then it comes back. So people will let this go on for quite some time because of these periods where it feels better, but it just keeps coming back. So the first thing I'd like to do is let's go over the anatomy. Now, I know this slide is daunting and you're going to feel like you're in medical school now. But let's look at the bones of the foot, and you're going to notice that, especially at the top there, that the bones are sort of a ball and cup, or ball and socket kind of joint. So the more vertical load that you have there, the more weight you have on the foot, the more stable it is, because those bones, they fit, like ball and socket. So the more they press into each other, the more stable they are. So that's such a perfect system because, if the bones could take all your weight, you could stand and walk all day without really doing much work. So it's a really good system. So where do we get into trouble? Well, we get into trouble if there's a rotational force on the bones. Say, because of your foot type, you might have a, flat foot, an adducted foot, or a high arch foot. And then those bones, they don't really sit aligned to each other. So imagine tent poles, and they're not really, in the groove. Those tent poles cannot hold up the tent. So the weight will go onto the tension band on the bottom. That's the plantar fascia. You can see it there. Now, the plantar fascia isn't really designed to take your body weight. There's some other structures there that help out. You have the intrinsic muscles on the bottom there. And you also have the extrinsic tendons that go into the arch of the foot. So they help out a little bit, but it's really the plantar fascia will take the lion's share of the weight if your bones are not aligned properly. And then you have another problem in the back there. You're going to see that big yellow arrow, and that's pressure pulling up because of the Achilles tendon. Now, the Achilles tendon is inserting a little bit off center, and there's a tug of war between the heel bone and the Achilles tendon. So if the heel bone is losing the tug of war, because it's not in the right position, the Achilles tendon will have a overwhelming mechanical advantage, and that means that your calf muscle will become tight. So it's adding gas to the fire there because you're pulling the heel bone up because now the Achilles tendon has a mechanical advantage. And that's going to elongate the foot. And you could imagine that if the foot gets longer, that plantar fascial band is going to be under even more tension. So what's going to happen is you're going to get to the, the limit of that band to elastically stretch. So you're going to get micro tears and fluid forming between the fibers of the plantar fascia, and that's inflammation of the plantar fascia, and that's what causes the heel pain. And then one last thing here, I'd like you to look at on the right, you see the anatomical, the other view of the plantar fascia. And I want you to notice two things about it. One is the shape, which is like a Japanese fan, that it's small on the bottom and it flares out, to all the toes. And that structurally with those fibers, splaying out, and deviating from each other, is actually could be a point of weakness because the tears are going to go in the direction of those fibers. And you could see how easy it would be for these fibers to split apart. So one thing is the shape, it's easily damaged. And then the second thing I'd like you to notice is that the tissue is white, which means there's not a lot of blood supply there. Like the muscles, you see they're red because they're supplied well with blood supply, but the plantar fascia is not. So blood is bringing nutrients and oxygen and everything that tissue needs to heal, and you're not getting that here. So think of the double whammy problem there, the shape of it, easy to injure, and the lack of circulation, difficult to heal. So let's talk about treatment options. Now, if you're watching this video, probably, I'm sure you already tried number one. Just ignore it and hope it goes away, because I told you it will go away for a couple of days and you're very relieved, but that doesn't work. It just keeps coming back. So you have conservative treatments or surgical treatments. Now, when I started out, I was in the OR. I only did surgical treatment for plantar fasciitis, which was to resect the plantar fascia and to excise some of the calcaneal bone. So I only treated plantar fasciitis with surgery. But you see, I have that crossed out now, because as years passed and I was in private practice, I found that the surgical patients, their foot was weaker and they were prone to other injuries. So I actually, not only do I never do this surgery anymore, I also recommend that you never have that surgery. So we're really looking at conservative treatment. So let's talk about that. And of course, we're going to start with home treatments for plantar fasciitis. You're going to start at home. And even if you are already seeing a podiatrist or you plan on seeing a podiatrist, you should start home treatments for this as soon as possible. So I would say the most common home treatment is taking over-the-counter non-steroidal anti-inflammatory drugs, Motrin, for example, or ibuprofen at 600 to 800 milligrams 3 times a day. Or you could take Aleve, which is naproxen. That's 2 pills twice a day. That's patients are more compliant when they're taking the Aleve. If you have any stomach problems, I don't recommend taking these drugs, and you have to check with your doctor if maybe you might not be allowed to take these medications. Or you start taking it and you have stomach problems, just stop taking it, because we don't want you to have a stomach problem and a foot problem. You know, that's no good. You can also do contrast baths. That's where you take 2 tubs. One is with ice water, the other one is with warm water. You go 10 minutes in each one, and this is proven to be very effective, contrast baths, to reduce inflammation. In the other tub, you see somebody soaking their foot in ice water while they're stretching, so it's 2 things at once. And then on the bottom is the frozen water bottle. You rub your bottom of your foot on that feels good. Or the Dixie cup with ice in it. Now, you want to reduce tightness. You know, remember I was telling you that the Achilles tendon is really tight. So ways to reduce tightness in the calf muscle is with different devices. And the goal is soft tissue release in the back of the calf. Remember I was telling you that the Achilles, is really pulling on the back of your calf muscle. So you can do soft tissue release with the ball that's on the yoga block there in the first picture, or the foam roller, or the hand device, which you can roll up and down. It's to increase circulation, and some theory is that you're kind of injuring the tissue, so it brings more blood supply and the muscle will relax. And of course stretch. And I was just at a lecture today and the doctor was talking about plantar fasciitis, and he said you should stretch and then stretch and then stretch and then stretch and then stretch. That's exactly how he just said it. And now reducing tightness, use the towel stretch in the morning, especially before you get out of bed. You can passively stretch your calf muscle with the towel. There's sleeping splints that stretch your calf muscle while you're sleeping. The Strasbourg sock, and on the right is the posterior pneumatic splint. Those are very effective. The one on the right, our podiatric assistant calls the marriage wrecker. Now, if you've tried all these things and after a month, 4 weeks, 5 weeks, 6 weeks, you're really not getting significantly better, then I would recommend that you do see your local podiatrist or orthopedic surgeon about the plantar fasciitis, because in the beginning, remember I told you had the micro tears with the fluid between the fibers, but over weeks, 4 weeks or up to 8 weeks, you start to have collagen degradation of those fibers. The fibers start to actually die, and then it becomes much harder for that to heal. So definitely try things at home, but not for too long. If you're not getting better, and a lot of people get better. But if you're not getting better, you should go to your doctor. Okay, so when you go to the doctor's office, they're first going to take a medical history, and the first thing that they're going to ask you is how long have you had the symptoms? And the reason why they're going to ask you that is because the longer you've had the symptoms, the longer it'll take to go away. And then the doctor will also ask you what treatments you've tried in the past. You may have gone to other doctors. I sometimes have patients who come to me with plantar fasciitis and they've seen 6, 7, 8 different doctors. So really keep track of what treatments you've tried, because the doctor is going to ask you that. And then the doctor is going to do a diagnostic examine your foot, looking for swelling, redness. Is it hot? Do you have plantar fasciitis? You know, some patients come in to me and they don't have plantar fasciitis. They say, oh, I'm here for my plantar fasciitis. My neighbor told me that, but they don't have plantar fasciitis. The doctor may take an x-ray. You might see a collapsed foot on the x-ray once, you know, in a blue moon. I've actually never seen it, but I've heard that you can see a calcaneal stress fracture. So you might find something very rare. Usually podiatrists don't do x-rays for plantar fasciitis because it's really a clinical exam. The doctor may do a diagnostic ultrasound. That shows soft tissue very nicely, so the doctor may do that. On the left, you see the normal plantar fascia. It's filled with gray, healthy collagen fibers, and it's also narrow. In the middle picture there, you see the plantar fasciitis plantar fascia. And it's black. You know, we joke that anything black on the ultrasound is bad. It's also very wide, so it's filled with fluid. That's what makes it so dark, and it's very wide, which actually means that it's also very weak. So a plantar fascia that's holding up your foot, but it's very weak, is going to be very easily re-injured. So think about how difficult that is. You know, it's an injured tissue that actually easily gets re-injured. That's a problem. And then, of course, the patient is you're going to ask your own questions to the doctor. So everybody always, first thing they ask, how long is this going to take to get better? So the rule of thumb is if you've had the pain for over 3 months, it's going to take at least 3 months to get better. And if you've had the problem for only a month or so, or 2 months, then it's going to take about a month to get better. And what is the process of getting better? What's the theory behind the treatment? So number one, reduce the pain and control the load. So the first thing, you know, the doctor really wants to reduce the pain. You know, that's what you want. You want less pain. So controlling the load means, like in the morning when you go to stand on it and your foot accepts the load, it really hurts. So, you know, you want to control the load. You want to repair the injured tissue. I showed you that, you know, I was explaining that it gets so easily re-injured. So it's really important to repair the injured tissue so it can't get re-injured. And then the last idea is that you're going to restore proper function, which is probably how you got into trouble in the first place. So that's more in line with thinking that, you know, you never want to have this come back. So here's my plantar fasciitis checklist. So we go through things, the patient and I, especially in the beginning when the patient first comes in, you know, oh, have you tried a night splint? You know, check that box. And are you doing stretching? Okay, check that box. You know, so we keep ourselves really organized. I love lists. You know, I have a million to-do lists. You know, every day I make myself a to-do list. So now the idea of a list like this is you don't want your treatment to be random or hit and miss and, hey, we didn't try this yet, you know. You want to have like a, you know, advancing logically and in, you know, more complicated types of treatment and not to forget anything. And the other part about the checklist is that it's true that combination treatments can improve effectiveness, but combination treatments can also get very confusing because you forget what you've been doing. So you have seen the doctor. They might prescribe a prescription anti-inflammatory. If your stomach can take it, you know, tell the doctor if you have any stomach problems. And also, if you have any stomach problems while you're taking it, then you know, like I told you, even with the over-the-counter NSAIDs, stop taking it if you have any stomach problems. The doctor may give you a cortisone shot. I'm very slow to give a cortisone shot. I think I do it maybe on 1 or 2 patients a month, which is pretty rare. Because the cortisone shot is very good in the short run, but it doesn't really repair the tissue. So the occasions that I use it would be if the patient was in, you know, pretty severe pain, like I would say 7 or 8 on a scale of 1 to 10, or the patient has a once-in-a-lifetime kind of event coming up. or once in every few year kind of event coming up and they can't walk, I might do a cortisone shot. Another type of shot that's very popular is the amnio shot, which is actually hyaluronic acid, usually. And that's a very nice injection because it's a harmless protein basically, and it's a very watery substance that gets absorbed by your body in only in days or a couple of weeks maybe. But what it does is it triggers the formation of stem cells from the body, and it also triggers growth factors, which is great because that initiates a repair process of the body. So and they call them amnio injections, but it's actually usually hyaluronic acid. It's very harmless, and it's can trigger healing. It works, I would say, about 90% of the time. It has a high success rate. Doesn't always work, but it's very expensive. So it's not really, in my practice, not a first line of treatment, but just because of the expense. There's also different physical modalities. A lot of podiatrists really love shockwave, which causes an injury to the tissue and wakes up the tissue to start the repair process. I prefer the laser therapy, a class 4 laser. And this is kind of a complicated slide, so you could pause it if you want to. But I'll just say that the laser, which is laser is an acronym. S is stimulation of energy radiation. And it stimulates vasodilation, or the energy, triggers the circulation to increase, which is called vasodilation. And that causes a positive pressure in intercellular fluid. And the lymphatic vessels rely on a very passive system of going from positive pressure to negative pressure, almost like a vacuum, you could say. So triggering the lymphatics encourages the area to be cleaned out of damaged tissue cells and fluid, toxins, and metabolites. So with a nice clean house from the lymphatics working, the body can really put the building blocks in there to start repairing the tissue. So that's one of many things that the laser does. So I've had very good luck with my laser. When you go to the podiatrist, they're going to recommend a particular shoe for you. There's so many different shoes. Back many years ago, there were only like 2 good shoes that took orthotics and everything. But now there's so many. Now it's the opposite. Now there's so many, it's confusing. So the podiatrist will look at your foot, how it's shaped, and then tell you which shoe will fit the shape of your foot the best. And then the podiatrist may give you a custom molded orthotic device. That's a no-brainer because that will take the pressure off the plantar fascia. And you remember I was showing you how the bones have to align so that the bones can bear the weight instead of the plantar fascia. And that's what orthotics do. So now you don't want to put any pressure under the plantar fascia or under the arch. So you could think of an orthotic sort of as an anti-arch support in that sense. Many times patients come in and we see no wear at all, or deformation of the material under the arch. We'll see it everywhere else, and then you know for sure that the orthotic is doing a good job. Versus like insoles, like super feet, and those things are actually like arch supports, putting pressure right under the plantar fascia. The podiatrist may also tape. Podiatrists usually are very good at taping. It's very difficult to tape yourself. Once I had tendonitis and I went to a podiatrist and they taped me up and it felt great and I healed up really quick. So just to go back into orthotics a little bit, so the idea of orthotics is that they relieve the high pressure areas. They're going to redistribute the weight away from the injured area. And to do that, they need a customized model of your foot or a scan of your foot. So you see the before orthotics, the person's the heel bone is at an angle to the leg, but with the orthotics, the bones are nicely lined up the way they should be. In the middle, you see the flat foot. You can also get plantar fasciitis from the high arch foot. I'm one of the only podiatrists in the United States that makes handmade orthotics from a cast for my own patients. So doctors in New York City send me patients, and I don't get the easy patients. I usually get very difficult patients. So I usually get the high arch patient with the plantar fasciitis. On the right, you see the good patient is wearing the orthotic, and the arch looks very nice. And you see that the weight is distributed all around the arch and the heel cup. And then on the bottom, you see the naughty patient who is not wearing the orthotic. And you see the sagging of the arch. But also notice that the on the bottom, that foot is longer than the one on the top. And I was explaining to you on the anatomical drawing that, you know, the longer the foot, the more the strain on the plantar fascia. And then the podiatrist may also give you a compressive sleeve that's really just for plantar fasciitis. There's many of these socks. Every podiatrist has their own favorite sock, and they're very inexpensive, so the podiatrist either has it in the office or they'll give you a link. You can get one of these plantar fasciitis socks. And then the very last slide that I want to go over with you is the plantar fasciitis treatment evaluator. And the purpose of this is really to use, as we're going along. So, and like I said, there's a logical progression for how you treat the foot. So first you want to start out with the most simple things, but the simple things can be less effective to the most complicated thing. So, it's the, the saying, the KISS principle, keep it simple, stupid. So keep it simple. So the bottom, just get more sleep, try to ice your foot, Now I have orthotics up, at the top there, and I really think, I don't think you can get rid of plantar fasciitis without a good pair of orthotics. So orthotics are one of my go-to things. So I do recommend orthotics. So, well, I hope this was helpful for you, and my takeaway points to you are to stick with treating this with the podiatrist. You are a partner with the doctor because you're working on this 7 days a week. You only see the podiatrist for so much time, maybe once a week. So the podiatrist can do so much, or the physical therapist or whatever, whoever's helping you can do so much. But you have to do it every single day. So really try to stick with it. And the second thing, I recommend that you keep yourself very organized. So why don't you keep a record of your symptoms and keep a record of your treatments too, because that will keep you on track. So you can keep chipping away at this. And every day that you work on this a little bit, you will get a little bit better. But plantar fasciitis, and I showed it to you, it's frequently people come after they've had it for a long time. So you're talking about at least a 3-month process for this to get better, but it's not uncommon to see someone taking 6 months to get better. It can take a long time, and it's depressing to the patient. So what I wanted you to take away from this is that don't get depressed. Just keep at it. Just be hopeful that it's going to go away, and I know that you can do it, especially if you think about that anatomy. And you're thinking about your calf muscle and the bottom of the plantar fascia and the support you need for your bones. You can do it. So good luck with that. And, let's get rid of your plantar fasciitis. Thanks.